Good day, my name is Sheila Power and I am currently enrolled at Regis College pursuing a master's degree in psychiatric mental health nursing. My current practice area is with the geriatric population, many of which have a diagnosis of dementia. My education and clinical practice has sparked a strong interest in person-centered care, in which I have personally witnessed firsthand the success of treatment of a person rather than a disease. I live and work in a rural community where many of those with whom I work, both my coworkers and my patients, have lived in this area their entire life and have limited access to evidence-based practice. My research proposal is titled Recognizing Barriers to De-Prescribing of Antipsychotic Medications in Individuals Diagnosed with Dementia. My initial research focus was directed to physicians and policymakers in the long-term care setting, but my review of available literature indicated that the greatest need for research is with those who deliver frontline care to those residing in long-term care, such as nursing assistants, unlicensed personnel, and licensed practical nurses. I began my work in dementia care as a certified nursing assistant on a locked dementia unit. I saw firsthand how poorly equipped the staff was to meet the needs of these patients, especially when the patient was agitated, restless, or experiencing auditory or visual hallucinations. Apparently, I wasn't the only one who saw a need for change in the care of dementia patients. In 1987, the Omnibus Reconciliation Act included the Nursing Home Reform Act, which sought to address care deficits in long-term care facilities. The Nursing Home Reform Act targeted the occurrence of abuse and neglect in long-term care facilities with the goal of creating facilities that were patient-centered and working towards increasing the quality of life for individuals residing in long-term care. One of the goals of the Act was for nursing to be educated in methods of care that improve quality of life. Unfortunately, little improvement was seen following the passage of this Act, and in 2012, the Centers for Medicare and Medicaid recognized that antipsychotic medications were continued to be overused in the long-term care facilities. CMS set out guidelines to decrease the use of antipsych medications by 15% in 2012, with steady increases in reductions by 2018. Prior to the involvement of CMS in attempting to decrease the rate of antipsychotic use, many patients exhibiting even mild neuropsychiatric behaviors such as agitation or restlessness were prescribed antipsychotic medications. CMS required that long-term care staff make every effort to utilize behavioral interventions to decrease neuropsychiatric behaviors, with the use of antipsychotic medications being a last resort. As of 2018, the literature reflects a consistent decline in prescribing rates of antipsychotic medications in long-term care facilities. Despite the CMS requirement, the prescribing of antipsychotic medications still continues for patients exhibiting neuropsychiatric behaviors in long-term care facilities. A review of literature found a number of reasons for this continuing practice. Physicians cite a lack of financial compensation for the in-depth care of individuals diagnosed with dementia, and lack of formal education in management of dementia care, and also an unwillingness to go against the request of long-term care staff and family members who feel that the use of these medications is the best method of management for the neuropsychiatric behaviors. Although CMS has the use of person-centered care as an approach to the care of patients diagnosed with dementia, what is frequently observed in observational studies is that the patients most in need of behavioral interventions are ignored in favor of those residents who are readily cooperative and voluntarily participate in scheduled activities. The use of spontaneous, individualized interventions is not utilized as an intervention for an agitated or restless patient. Although there is much discussion about individualized care and person-centered care, often these individuals who are directly responsible for the care of patients are not educated on these concepts. Likewise, dementia is a complex illness with multiple manifestations. Do those who provide care have a basic knowledge of this disease and the associated symptoms? It is possible that by providing basic education to direct care staff, that the presence and severity of neuropsychiatric symptoms could be decreased or even avoided. Through my research, I hope to gain an understanding of the motivations for administering antipsychotic medications. Are there specific policies within the facility that mandate when these medications are administered? Do frontline staff feel supported in the use of individualized care for dementia patients? By directly asking these questions of those staff members who are administering the medications and gaining an understanding of who knows what, I believe I may find that many staff members have been provided few resources to help develop a skill set for managing neuropsychiatric behaviors other than the use of psychiatric medications. The literature is not without research studies discussing barriers to the deprescribing of antipsychotic meds. However, there isn't an abundance of research that directly evaluates the role that direct care staff in long-term care facilities plays in the use of antipsychotic medications. Many of the frontline care staff in long-term care facilities have minimal education, such as a licensed practical nurse who receives only 12 to 18 months of training before being placed in a role to determine what is most appropriate and effective intervention for dealing with dementia patients exhibiting neuropsychiatric behaviors. Likewise, long-term care facilities frequently employed unlicensed personnel with minimal training to provide the majority of care to the residents of long-term care facilities. Although the term person-centered care may be one that is familiar to them, do they have a thorough understanding of this concept as well as the support of facility administration in administering this type of care? Participants in this study will be obtained through the use of convenience sampling. Certified and non-certified nursing assistants and licensed practical nurses will be offered the opportunity to participate in the research project during educational in-service meetings. The long-term care facility has 90 beds, with 20 beds being in a locked unit. Staff from all areas of the facility will be eligible to participate, as dementia patients are not solely confined to the locked unit. Those who are willing to participate will be provided with information about the research as well as informed consent. Participants will be provided the Dementia Knowledge Assessment Scale and the Individualized Care Instrument to complete during scheduled education hours. Observations by the researcher will be completed during times that study participants are working. The facility administration has agreed to provide extra staff to cover patient care during interview times. The interviews will occur within 15 minutes of the administration of an antipsychotic medication. Data obtained from the Dementia Knowledge Assessment Scale and the Individual Care Instrument will be analyzed using SPSS software. Individual interviews will be recorded and prescribed verbatim. Observations and interviews will continue until saturation is reached. I would like to rephrase that as transcribed verbatim. Simply having a facility policy in order to satisfy a regulatory requirement is not sufficient. Having an understanding of knowledge gaps for staff at every level allows facilities to fill those gaps through appropriate training and gives a voice to those who provide the frontline care to patients. Having adequate knowledge of the reasons for neuropsychiatric symptoms and the confidence to intervene early to avoid the need for medication administration will allow for confidence in care providers to take initial steps earlier in the process without fear of retaliation by management. As nurses, our goal should be to recognize that a person is more than just their illness or symptoms of their illness. By removing barriers to seeing individuals not as a diagnosis to be managed, but as a person to be cared for, research that attempts to move individuals from the role of the patient to the role of the individual who has the disease that requires management should be the goal of nursing. Acting as an advocate for individuals is required by the American Association of Nursing Code of Ethics and should be the goal of each nurse when caring for individuals. Dementia rates have been found to be more prevalent in rural communities versus metropolitan communities, with the inverse true for research funding. Rural communities receive only pennies on the dollar when compared to urban communities. Between 2005 and 2010, only 2% of grant funding was awarded to medical research in rural communities. Much of the funding provided to rural communities is marked for higher education as well as infrastructure improvement. Sir et al. Found in their research that the majority of educational funding was directed to create policy in dementia care, not to those who deliver the care. Funding of this research would benefit a rural community as well as those who provide direct care to the individuals. There is no question that this research is important to dementia patients, their direct caregivers, as well as the community in which they reside.